Hello everyone, this is Dr. Tejaswini SR. Today I am here to teach you regarding Bartholin gland, its anatomy, its embryology, what happens to the pathology, that is Bartholin gland cyst, abscess, and what to do when there is recurrence. Okay, so I have taken the photos from T. Linde's Apparative Gynecology textbook. Okay. So Bartholin gland, it is present in the lower part of the vulva. It is covered by bulbospongiosus muscle and it is a counterpart for bulbourethral gland in male. It is present in the superficial perineal pouch. When it comes with the embryology, it is derived from urogenital sinuses. So the gland is very small. The gland is small where the duct is long. So the gland is just 0.5 to 1 centimeter and the duct is 1.5 to 2 centimeter long. So whatever the secretions from the Bartholin gland is mucoid in consistency and its pH is 4.7. The secretions are rich in potassium and low in sodium, and the secretions mainly comes during the act of coitus. Okay, so what is the epithelium lining a Bartholin gland? As I already told, the gland is lined by columnar epithelium. Then the duct is then that is transitional epithelium. When the duct opens towards the introitus, that is here, then the epithelium changes to squamous. That is from columnar to the epithelium is transition to squamous epithelium. So this is in brief about the anatomy and the whatever the secretion, that is the physiology of Bartholin gland secretion and the embryology. When it comes with blood supply, it is supplied from external pudendal artery and nerve supply from pudendal nerve, and the lymph node drainage is by superficial inguinal group of lymph nodes. The Bartholin gland is for exam purpose for both UG and PG. It is just 3 or 5 mark question. So you should start from the anatomy, physiology, and even the blood supply, nerve supply, and lymphatics. So what happens? So when there is an sexually transmitted disease or infection happens, there will be Bartholin cyst. So this is the diagram showing Bartholin cyst. Okay. So what happens when there is sexually transmitted diseases such as Neisseria, gonorrhea, or chlamydia? So those infections will block this duct. When the duct is blocked, the secretions from the Bartholin gland will stay inside the Bartholin gland. So initially but the infection will not spread. So initially there will be Bartholinitis, also called Bartholin cyst. When the infection invades into the gland, then only it is called abscess. Initially it is called cyst. When the infection invades, it is called abscess. Okay. So how the patient presents? What is the clinical features? The clinical feature is some excruciating pain. We always encounter emergencies mostly during obstetrics, and we will be hurry-burry in obstetrics. But when we are seeing a gynecopy, we will be cool, calm, and aram se we will be seeing. But when the Bartholin gland abscess patient comes, she can't even sit, she can't even walk, she will be wincing with the pain. So that is such a excruciating pain happens in Bartholin gland abscess, and there will be local warmth and local tenderness. Patient will be having fever. These are the clinical features. Okay, so any abscess, what we think usually, one thing, anything fluid is collected, either we can do aspiration, or if abscess we will proceed with incision and drainage. So the next thing is, here the preference what we give for is Wood's catheter and marsupialization. So let us go one by one. What happens when you do aspiration? See, this is a gland, here the fluid is collected. See, as in this diagram, this is the cyst. In the cyst there is fluid. When you put a syringe and aspirate, it will relieve the symptom for a short period of time, but it will not relieve the pathology behind it. So there is chance of recurrence when you do aspiration of the cyst. When you do incision and drainage, just you put incision and drain, again it will recur. Again it will relieve the symptom for a just period of time, but it will not relieve the pathology. So what we prefer is putting the Wood's catheter. So this is Wood catheter, W-O-R-D, Wood catheter. What happens when you put the catheter inside? So the catheter, you have this long arm, na? So this long arm. So it creates like a new duct. It acts as a new duct. When you remove from the fluid, you are removing from the gland whatever the collected fluid, pus you are removing it. But the main pathophysiology is duct is blocked. So you will put a Wood's catheter such that the whatever this globular shape is there, that will fit into the gland, and this rod like thing that is there in the duct. So it forms a neoduct. So when there is neoduct, you will remove it after some days, and that there will be reepithelialization which has formed, and the duct is now functional. So there is less chance for recurrence. Now this is with respect to the Wood's catheter. Then this diagram, whatever is there, it is showing marsupialization of Bartholin gland. See, you are putting incision over the Bartholin gland, and then approximation of the cyst wall is there, that you will approximate with the skin. Here this side and that side. So the whatever the cyst is there, it's open for some time. So this is called marsupialization. So the approximation of cyst wall and skin to create a fistula for drainage, that is marsupialization. So this is preferred when you are not putting word catheter, you will prefer this marsupialization. So even after doing marsupialization, still it is recurring. So whenever the patient presents with abscess, first thing is to rule out immunocompromised conditions like HIV patient or a patient who are diabetic, they are prone for recurrence. So when there is recurrence of Bartholin gland, then what we prefer is this, that is excision of Bartholin gland. So there is enlarged Bartholin gland. So you have given incision of the epithelium overlying the gland and enucleation of gland, and then excision of the base of the gland and Bartholin gland cyst. This is the diagram which is showing excision of Bartholin gland. So when it comes with the cancer or malignancy changes, it is very rare. 1 in 10 lakh patients will get cancer in Bartholin gland, and when it happens, it is squamous cell carcinoma. So do you prefer, we can do excision in the first thing itself, na, instead of doing aspiration or marsupialization or putting wood catheter. The thing is, the Bartholin gland excision is not that easy because it is very vascular. When you are excising it, there is high chance of torrential hemorrhage and hematoma formation. These are the risks of Bartholin gland excision. One is you can remove incompletely, or there can be hemorrhage, or there can be hematoma, and loss of vaginal lubrication postoperatively. There may be scarring, chronic pain, and dyspareunia. So this is in brief about Bartholin gland and its abscess. So thank you for watching this video. Kindly do subscribe to my channel and do comment for more such videos. Thank you.